Thank you for waiting till the end. Yeah, I'm the last person standing between you and a long weekend, a good, nice weekend. Okay, so for both the audience in the room as well as for everyone who is joining us from the Zoom, if you could just go on to the slido.com or scan the QR code and enter this username. Sorry, enter this code and then put it in your username so you can get connected with the polling. It's going to work pretty much like any other polling app. So we can see the audience response, we can see the answers, and the images will be up on the screen and in the Zoom. Okay, I'll give another 2 minutes, then we can start with the quiz. Okay, everyone in the audience, have you logged on already? Can we proceed? Okay, so it's just a straightforward quiz with 10 questions, or rather 10 cases. And yeah, let's go on. So this is the first question. So the first case is a 32-year-old Indian male who's working here in Singapore. He presents with transient unresponsiveness and also has had history of long-standing headaches. So these are the images. We have a T2 post-contrast, T1 axials, and heavily T2-weighted sagittal. So what is the diagnosis? You can just say A to E, which one? You can look for the questions either on the screen or on your Slido app as well. So you see a few cystic appearing lesions in both thalami, and you don't see much of enhancement. And on the sagittal, you see the lesion occupying the basal cisterns, going into the some signal abnormality in the cerebral aqueduct, going on to the fourth ventricle. Okay, shall we have the polling results? So we can close the polls and show us the answers. Okay, so over 40% gone for neurocystic psychosis. I think the poll is still on. Yeah, 41 went for NCC. Next best answer was perivascular spaces, then TB meningitis. Okay, I think we should stop the polling before we display the answers, I guess. Then people are more going with the majority. Yeah, the crowd work is smarter, I guess. Yeah, the majority are right. So it is indeed neurocystic psychosis, but let me take you through the other options. So this is probably not TB meningitis because there isn't much of enhancement, and TB meningitis, as you see, is more thick enhancement, mostly in the basal cisterns, and we don't see that much here. About the perivascular spaces, Well, this is not exactly intraparenchymal, is it? There is it's a lot of extraaxial component as well. So this cannot be perivascular spaces. And the same logic goes with angiocentric lymphoma. Again, no enhancement, no solid components. And finally, GBM with CSF dissemination. Again, there's not much of a mass, a solid component to it. It's more cystic and no enhancement. So this is indeed neurocystic sarcosis. Next question, question 1B is what type of NCC is this? So this is more of a descriptive answer. You can just type it in if anyone knows the answer. Yeah, I know it's a difficult one. That's why it's the question B. It's like a bonus question for those who have answered it correct. Okay, we know the 4 types of NCC, right? The 4 stages. Okay, can we see the answers if anyone had typed in? No answers? Okay, first stage mixed cystic inflammatory colloid type 4 scolex racemosis. So Yod Kwan, I don't know if I'm pronouncing it correct. Yes, he did get the correct answer. It is, oh, there are some more answers, okay. Oh, I think someone has hacked into my account, I guess. All right, mindful kid. Yeah, so racemose type is the correct answer. So this does not fall into the 4 classical types of NCC that we know about. So here what happens is that either the lesion is intraparenchymal, then it bursts onto the subarachnoid space, or it starts primarily in the subarachnoid space. Since it doesn't have much of a physical confines, it kind of expands into the CSF space quite freely. So that's why you get this kind of picture where you can see it nicely cascading into all the CSF spaces, the cerebral aqueduct, foreventricle, and even tracking up into the third ventricle as well. So this is I mean, unusual and rare type of NCC known as racemose type, which means like a flower-like. Racemose stands for in Latin. Yeah, that's why it's in the quiz competition. Okay, so let's move on to the second question. I need to give a bit of a history here. So this is a 75-year-old female patient that came in with right hemispheric syndrome. The patient was quite late to present and had a right M1 MC occlusion. So since she was outside the window, no RTPA was given, no thrombectomy was done. So she went on to have a large MCA territory infarct. During the hospital stay, she was diagnosed to have atrial fibrillation. So she had a little protracted hospital stay. And before they wanted to start her on anticoagulation, they wanted to get a CT scan to exclude any intracranial hemorrhage. So these are the images. So this is during presentation. This is not the question of interest. This is the question of interest. Okay, so this is the current scan. 2 weeks later, done to exclude ICH. So the question is, what would you do next? Would you call the neurosurgeon in your hospital for urgent decompression? Or would you ever review any prior imaging studies that were performed? Or would you go for a further evaluation with CT or MRI? So if you scrutinize the scan, there is probably more than what meets the eyes. Let me give another 30 seconds, then we close the polling. Okay, let's close the polling. Right, so review prior imaging performed, further evaluation with CT or MR, both are top answers, and 17% went for surgical decompression. All right, so this, yeah, of course, on first glance, it looks more like a hemorrhagic conversion, and if it were a hemorrhagic conversion, there's quite a bit of hematoma over there, and that might need surgical decompression. Although, if you notice carefully, is there much of a mass effect? It's not there, right? So probably the hematoma is maybe 10 centimeter in size, but it doesn't cause much of a midline shift. So that is something that we need to take a second look at. The other thing which you should notice is that if you look at the sinuses, it appears hyperdense. So this is just a non-contrast CT, but the sinuses appear hyperdense. So the differentials, well, you can think of venous sinus thrombosis, but if this is probably what straight sinus region and maybe the vein of Galen in that region. So if those were to get thrombosed, the patient would definitely be more symptomatic, right? So all the drainage from the central regions along the internal cerebral vein, everything should be congested and the patient would be a lot more symptomatic. But this patient is fairly asymptomatic. The scan was only done to rule out ICH so they can go on to start anticoagulation. So that's probably not the case. So what else is differential? It would be any prior contrast administration, right? So this patient did have a CT contrast enhanced CT neck 3 hours before getting this CT brain. Our setup is like we have a Tantoxin hospital and we have NNI both together. So in Tantoxin hospital, they do some scans which we won't know. It doesn't pop into our packs. Earlier, this scan was about 5 years ago. So we have to manually go check if this patient had any prior scans. So that's one of the correct answers. Yeah, you have to check any prior scans if was contrast administered. And this was just contrast staining because the parenchyma has been disrupted. The blood-brain barrier is breached, so just contrast leaks out and opacifies the infarcted portion. So this is just cerebral contrast staining rather than hemorrhagic conversion. We had actually published it. And how we confirm, we can either do a dual energy CT scan, so that can differentiate between iodine and blood. So this patient was called back and subjected to a DECT. The image on your far left, that is the iodine suppressed blood only image. So we don't see any blood in it. Sorry, we don't see any iodine in it. It's the iodine suppressed. And the image in the middle is the blood suppressed iodine only image. There we see the exact dimension of the hyperdensity which we saw on the plain CT. So which confirms that this is indeed iodine and not blood. Well, the literature on this is this can happen in the subacute phase most commonly, but this also predisposes to hemorrhagic conversion. So the image on the left, on the right, it's a follow-up scan, I think done 5 days later, which now shows that the iodine has been resolved, but you still see some hyperdensities. But this is like a petechial hemorrhagic conversion. So because the blood-brain barrier is disrupted, it also predisposes to having petechial hemorrhagic conversion, but the large hematoma-like appearance was just iodine contrast staining. This is another companion case. You see the clear demarcation on the MRI, right PCA and SCA infarct, again showing hyperdensity on the CT. And this, I think, was a few months back. So you can see how the quality of the CT has improved. It's actually the same scanner, but the software has changed. Now you can see the iodine-only image as much clearer than it was before, like 4 or 5 years ago. All right, so this is also contrast staining. Okay, let's go to the third case. So this is also a 65-year-old man, a bit elderly. He complains of increasing sleepiness, reversal of sleep-wake cycle. He's awake in the middle of the night and he sleeps through the day and has some altered sensorium. It isn't too bad, but he's definitely finding it difficult. So he's come to the hospital. He undergoes an MRI brain. So the radiologists report a finding for which a liver function test was ordered. So this is the presentation MRI. Okay, we see some symmetric hyperintensity in a T1 weighted imaging in the basal ganglia. So the diagnosis would be something to do with the liver, right? Hepatic encephalopathy, portal hypertension, along those lines. So a liver function test was ordered, and the function LFT, the routine LFT was completely normal. All the parameters are within normal limits. So now we go on to the question now. What is the best possible explanation in this scenario? Either one, it could still be hepatic dysfunction and portal hypertension. For some reason, the blood investigation doesn't show that. Or is it fast disease? Or is it some primary pathology of the CNS, not a secondary thing related to the liver? Or four, none of the above? Yeah, this is one of the toughie. I think I probably only come across this case twice. Okay, you need to think along the lines of what? So why do we have hyperintensity in T1 in the basal ganglia? So it's because of deposition of minerals like manganese, right? That bypasses the hepatic filtration and gets deposited in the basal ganglia. Manganese is similar to gadolinium, has some unpaired spins, so that gives T1 shortening. So can that occur without any hepatic dysfunction? So that's the hint for this question. So we have the answers. This could still be hepatic dysfunction with portal hypertension. Yep, possibly. But the blood tests are mostly the screening scans, right? Like these are very non-specific, but probably good. They are sensitive enough, correct? Any of the parameters, AST or ALT, something should have gone wrong, right? Everything to be pristine, it's probably then the liver is not the culprit. The lesion is probably not in the liver. Okay, so this is a tough one. It's called an Abernethy malformation. I'm sure like many of you have not have heard about it. So this is a really uncommon situation where there is a portosystemic shunt. It's just a congenital abnormality. So normally the portal vein goes into the liver, right? Instead it opens into the superior vena cava. So it bypasses the liver. So there are again a few types in that. You can either open end to end, which means the portal vein directly opens into the SVC and there's no blood into the liver, so that's much worse. Or the more common is side to side anastomosis, which means just there is a anastomotic shunt between the two vessels, but still blood goes into the liver. So these kind of patients, if it is congenital, why would the patient present at 65 years? The reason is this: it's only a type 2 shunt. As you know, like in the elderly, they might have constipation or other problem. So there is buildup of bacteria in the gut. So more bacteria is like more ammonia, it's being produced, and that gets into the mesenteric vessels, the mesenteric veins, right? It gets absorbed. And some of it reaches into the portal circulation and causes the hepatic encephalopathy. That's the proposed mechanism. And treatment for this condition would be to get rid of the gut bacteria. Either they give laxatives so that the bacteria just goes away. We are just trying to reduce the load of the bacteria. Or there are some topical antibiotics like polymyxin. Those are really strong antibiotics, but do not absorb into the systemic circulation. So we are just kind of giving a topical antibiotic for the gut. Anyways, this is a lot more common. We again see a similar thing, but we look at the liver, then we see all the signs of cirrhosis, right? Portal hypertension, cirrhosis, some mesenteric portosystemic shunt happening. This is a lot more common than that. Okay, let's move on to the fourth case. It comes courtesy of Dr. Yu, who was a moderator for the previous session. So it's a young male, a young Asian male, who has like bilateral hand numbness, although there is some parity, like its left side is more than the right, and some neck ache. So he goes on to have a MRI of the spine, cervical spine. So we have T1 and T2. So what is the diagnosis? And this is a stir image. So we have T1, T2, and stir. I can describe stir. Doesn't look too much of an edema. The main finding is in these two sequences. And the clinical information is always helpful, right? It's a young male Asian. So since this is also a descriptive question, I can further elaborate. What do we see here? So we don't see any mass lesion in the spinal canal. We see the spinal cord. Maybe there is some abnormality in the thickness of the cord. It is not uniform. So where the cord is thinned out might give you a hint as to what is the diagnosis. Yeah, most of these questions are a bit more like Aunt Minnie. So if you come across it, you can diagnose it quite easily. But they're also quite specific, so that's why they are Aunt Minnie. Okay, we have quite a number of answers in front of me. Thinning of cord 6. Yeah, majority went with Hirayama. Yeah, I think many of you guys know this and this diagnosis. It is indeed Hirayama, also known as non-progressive juvenile spinal muscular atrophy. Yes, one of you have said need flexion views. That's absolutely correct. We can make the diagnosis easier when we do the flexion views, where you can see when the spinal cord bends over, then where the thinning is, that scratches along the vertebral body. So because of the pressure contact, like there are atrophy of the anterior horn cells, and that leads to the clinical presentation. And another classical finding is when you look directly posterior to the level of thinning, you'll see contrast enhancement or a crescentric T2 hyperintensity. So that's because there's dural thickening, which also shows enhancement. So this is the most classical description of this condition, Hirayama disease. It's full house. Okay, I think many of you have gotten it correct. All right, let's go on to the fifth case. It's a 57-year-old male who had a temporooccipital hemorrhage in an outside hospital, then was referred to our institute for further follow-up. So he first has a CT angiogram. So let me talk you through this. So the image on the left is the plain CT brain. The hemorrhage has resolved, so now we only have gliosis in the temporooccipital lobe. And the image on the left, I don't know how many of you can spot it. There is a early opacifying vein in the left temporal lobe over here, maybe in the 5 o'clock position. Sorry, again, my pointer isn't working. So you can see that vein, the temporal vein continuing onto this. So this is an CT angiogram, right? So it's done at the arterial phase. So usually we do not see the vein that well, but here the vein is opacifying to the same density as the artery is. So this is arteriovenous shunting happening. So the patient then went on to have an angiogram. So again, you see that abnormal vein that opacifies simultaneously with the artery. So this is the diagnosis would be a tentorial arteriodural dural arteriovenous fistula. So the question is, name the artery that supplies this fistula. There is a specific artery that goes along the tentorium and is usually supplying the fistulas in this location. So again, it's an intervention question. Since this quiz is common to all 3 days, if there are some budding interventionalists, can answer this one. Okay, eponyms in medicine. How many of you are for that and how many of you are against that? Yeah, there are both arguments on both sides. Like, of course, there are people who say that why do we even have eponyms? Like, there are too much things to remember and doesn't really suit the purpose. But I'm on the other group. I still believe in the eponyms. 2 reasons. One, it honors the guy who painstakingly described this condition. And 2, it's actually much shorter to remember the whole artery. I'll say why. Okay, let's close the polling and look at the answers. Okay, artery of Davidoff-Schechter gets the most, 63%, followed by Bernasconi, Krasnari, and then Wolschläger and Percheron. Nobody went for option E. Don't know why. Okay, so about the eponyms again. Normally, when there is an eponymous artery, so it is something unique. So what's unique about all these named arteries? As you know, the brain is supplied by PL arteries, right? And the dura is supplied by, or the meninges is supplied by dural arteries, which are branches of the ECA, external circulation. So sometimes the brain arteries, the ICAs or the vertebrals can supply the dura. So since that is the unique feature as to why these arteries are being given special descriptions. So artery of Bernasconi-Casanari, that is the meningeal branch, tentorial branch of the meningohypophyseal trunk, which itself is a branch of the ICA. So normally, basic understanding is that the first branch of ICA is ophthalmic, right? But if we ask the interventionalists, there are a few other branches which are very small, even not all the time seen in angiogram. So there are, at the cavernous segment of the ICA, there are some branches that go on posteriorly over here. You can see the cavernous bend. So there are branches that goes towards the tentorium and the sigmoid sinus. So that is the artery of Bernasconi and Casanari. So this becomes enlarged when there is fistula in the sigmoid sinus region or in the tentorial regions. It is present in all of us, but it is so small that it's not even seen in the angiogram. The moment that it gets enlarged probably signifies there is something going on wrong. And about the other 2 arteries, so even yesterday, Dr. Ramesh and Dr. Anjali spoke about these arteries. So yes, artery of Davidoff-Schechter is the correct answer. So this artery comes off the PCA. So as you know, the PCA goes on top of the tentorium and the superior cerebellar artery goes on the bottom of the tentorium. So even though these are PL arteries, since they are touching the tentorial surface, they can give some dural branches to the tentorium. So when this dural branch comes off the PCA, that is ADS, artery of Davidoff-Schechter. And when the dural artery comes off from the below, the superior cerebellar artery, that's the artery of Wolschläger and Wolschläger. Now you see the point, right? Instead of saying every time, oh, this is the tentorial branch of the meningohypophyseal trunk of the internal carotid artery, you can probably say Bernasconi-Casanari or at least ABC. About the artery of Percheron, I think that's more commonly known, that comes off the top of the basilar artery and supplies both thalami. Infarcts of the top of the basila can have infarcts in both thalami. What about E? Why no one went for E? If there were any fans of Sacha Baron Cohen, might know this.
Employees what? Employees مسوش
Yeah,
heads.
it's just, yeah. Not all exotic sounding names are indeed named after someone. That's all. Okay, question number 6. 73-year-old female has slowly progressive cognitive decline and altered mental status. So these are the DWI and ADC showing some striking abnormality. So what is the diagnosis? This disease is also is quite unique to NNI because we had described it and published on that. Again, it's worth noting where the DWI abnormalities are specifically present. That gives you the clue. Okay, let's close the poll and look at the answers. I think probably most of us, most of the audience will get this. Yes, indeed, they got, that's the correct answer. Yeah, the other distractors are pretty much quite easy to exclude. Prion disease, both prion disease and hypoxic ischemic encephalopathy, they are predominantly affecting the gray matter, the cortex, right, rather than the white matter. Here, the abnormality is predominantly in the white matter than the gray matter. And CBD, this is never the presentation. It never is this extensive. It's usually restricted to the motor strip region, the high parietal region. And I don't think they have much of DWI changes anyways. So it is indeed NIID, neuronal intranuclear hyaline inclusion disease. So this is a T1 and T2 of the same patient. You see extensive white matter abnormalities. It's kind of resembles the FX-TAS syndrome, but here there are some unique changes that distinguishes this condition from that. Here the DWA abnormalities are quite striking, and our consultants, Professor Choyson Lim and Dr. Yu Yang, they have described this a large case series from Singapore. I think probably this has the most outside of Japan. This condition is a lot more prevalent in Japan. So this is just another inclusion disease, hyaline, hyaline inclusion disease, where there's deposition not only in the brain, but also in the visceral organs and the skin. And the diagnosis is usually made by skin biopsy, but unfortunately there is no established treatment for this condition. It's more for prognostic reasons. Okay, a few more questions. So a similar situation, also an elderly male known to have prior breast cancer and brain metastasis, has undergone whole brain irradiation 9 years ago. Now presents with fever, drowsiness, and right-sided weakness. On examination, GCS is poor, but there are no signs of meningism. What's the diagnosis? I think this one is it's descriptive, I believe. You just have to type it out. Yeah, this is a corresponding T2 weighted images. Again, focus on where is the abnormality that might lead you to the answer. And this is a post-contrast images. I don't know if it projects well, but there is some enhancement, and the distribution of the enhancement will help you. And so is the distribution of the T2 changes. Okay, which territory is the involvement that can also help you? Okay, can we see the answers, please? Post-radiation necrosis, SMART syndrome, radiation necrosis, radiation-induced encephalopathy, radiation vasculopathy, radiation encephalopathy, laminar necrosis. Any more? Metastasis, carcinomatous meningitis, radiation infarcts, secondary vasculopathy. Okay, so we had quite a variety of answers. Yeah, when approaching this case, first we see anything abnormal with restricted diffusion, we first think of infarcts, right? So then we have to put this in a territory. So which territory does this fall in? Is it MCA or is it PCA or is it the MCA PCA watershed? It's actually a little more, it doesn't fit in any of the three, right? It's like a bit more extensive, straddling both territories. In fact, if you go into the the enhancement, you can see some enhancement in the insula as far anterior as the insula and as far as posterior as the bit of the occipital lobe. So certainly one vascular territory or a watershed cannot explain this picture. And in the last image, you also see some leptomeningeal enhancement. I think that's why one of the participants had mentioned carcinomatous meningitis. That is in the differential, but with the DWI changes and prior history of whole brain irradiation, with the presenting complaint of hemispheric syndrome, SMART syndrome is the correct answer. I think one of the participant got it correct. And this is the MRA, by the way. And there was no large vessel occlusion on the involved side. So this is SMART syndrome, also known as, it's an acronym for stroke-like migraine attacks after radiotherapy. The pathophysiology is not entirely clear, but it can occur many years, like even 1 to 10 years, or even more than that after radiation of the brain. It presents just like migraine with hemiplegia, and it is disappearing and fleeting. So it can disappear at one location and 6 months later it can prop up in another place. So those are the characteristics of this condition. So this patient, I think some of my images are missing. Anyways, this in the follow-up scan done 6 weeks later, there was complete disappearance of all those findings. Okay, so we go on to our last 3 questions. Okay, this question comes courtesy of Dr. Vivek Pai. He was in Seven Hill Hospitals in Mumbai, India, and now in Toronto, University of Toronto in Canada. So it's a 65-year-old male. It's a more recent case. He was diagnosed with COVID, and then he had some fever, blurring of vision in his right eye. The question is straightforward. What is the diagnosis and what is the diagnostic sign that you see in the 3 images provided? The first image from the left is the T1 pre-contrast. The middle image is the T1 post-contrast. And the last image is also T1 post-contrast, but little posterior than the image on the middle. You see something, you don't see something. So what do you see and what you don't see? So during the COVID pandemic, there is also kind of a serious situation happening in India, if any of you would know that. Okay, can we see the answers? Superior ophthalmic vein thrombosis, mucormycosis, black fungus sign, mucormycosis. I saw the sign. I think my phone is seriously hacked or someone is trying to play pranks on me. Invasive fungal sinusitis, induced cavernous sinus thrombosis, orbital apex syndrome, fungal sinusitis, invasive fungal sinusitis, black turbinate sign. Yes, Chin YL got it correct. So this indeed is mucormycosis. As you know, there was also kind of an epidemic of mucormycosis in India because of the COVID. A lot of people with diabetes in India. India is one of the diabetic capitals of the world. And also, the COVID acts on the ACE2 receptors, which are present in the pancreatic islet cells. So it blocks that function and precipitates it creates more of a diabetogenic state. So these were some of the hypotheses that was put forth why the diabetic patients are doing so poorly with COVID. And also many patients receive steroids, right, for treatment of COVID, and the immunity is also low. So those are multiple combination of reasons that led on to kind of a small epidemic of mucormycosis. And these are some of the complications. And the sign that we are looking for was indeed the black turbinate sign. So if you look at the middle image, so this is a post-contrast image, you don't see the enhancement of the turbinates on the right side, both the middle and the inferior turbinate. But on the left side, you see the regular normal enhancement. So that's the correct answer. So the mucormycosis is quite invasive. So it kind of tracks onto many spaces in the head and neck and the brain. So these are all manifestations of mucormycosis. Dr. Pai had published on this. So the image on the top left is invasion into the optic tract, optic canal region. The image on the top right is bony invasion of the skull base. The bottom two images are intracerebral extension with brain abscess formation. And the top row images are vasculitis induced by mucormycosis with subsequent infarcts in the perforated territory. And the bottom three images are also extension along the V2, V3 branches of the trigeminal nerve, tracking posteriorly up to the brain stem. All right, last two questions. This comes courtesy of Dr. Anil from NUH. So, it's a 54-year-old female patient has insidious onset pulling type of headache, which improves on lying down. So these are the coronal and sagittal post-contrast and FLAR images of the brain. What is the diagnosis? So what do you see on the FLAR images? And what do you see on the post-contrast images? The patient is 54, so probably post-menopausal. Does it have anything to do with the pituitary appearance? So this is a two-part question. The first part is you put the answers in the chat. Okay, let's give another 20 seconds. Okay, let's reveal the answers, please. Yep, most of them got it correct. After Dr. Dobroxi's excellent lecture yesterday, everyone got it correct. The second question is, which of the parameters is not used in the calculation of score for the brain SIH score? It's a bit more technical, but look at the answers. You don't have to refer to the internet or anything. Look at the answer, which is the odd man out. I'll go back to the picture so you can visually see where those distances, where those calipers would fit into. Is it suprasellar cistern distance, prepontine distance, anteroposterior midline midbrain diameter, or mammaropontine distance? By the way, all four are established markers. It's not like a made-up name like employees must wash hands. Okay, let's have the answers. Again, exactly 90% and above got it correct, thanks to Dr. Thomas. So the AP diameter of the midbrain is 4 PSP, right? The hummingbird sign and midbrain atrophy. So we have 3 objective signs, 3 subjective signs for the calculation of the score with a total of 9. And this patient had a MR spine, which was negative for SLEC, for the epidural collection. And recently we did the CSF digital subtraction myelogram for this patient and found a CSF venous fistula. Okay, so we are up to the last question. It's a 78-year-old male with lower limb weakness, I presume on both sides. What is the appropriate treatment option in this patient? So again, there are 3 sagittal images of the spine. Look at the what sequences they are. I'll point out the abnormality. Sorry, again, no marker, but it extends from T4 level until T9 on the posterior aspect of the dura. So the question is, what is the next treatment approach? Is it epidural blood patch, or you send to a spine surgeon to fix the CSF leak, close the tear, or embolize the spinal vein, or none of the above? These are the images. I'll give another 20 seconds and then we'll close it for the day. Okay, let's look at the answers. None of the above. Then you should put in the chat group, what do you want to do? Or what is the diagnosis? Can they put in a chat group, or will that be displayed? What is the diagnosis? Okay, anyways, I think most of the people didn't fall onto the trap, because if you look at the sequences carefully, in T2 there is may appear like a SLEC. It's hyperintense on T2 on the posterior aspect of the dura, but on the STIR, there's no signal from that. It is suppressed. So if it were a fluid containing SLEC, it should be appearing bright on the STIR image as well, right? But here it's suppressed out. So STIR suppresses fat. So this longitudinal signal abnormality contains fat. And that's why it is appearing hyperintense on T1 on the last image. And I was just trying to pull your legs, but you are quite clever. So it is indeed just spinal epidural lipomatosis. It's kind of a differential for that, not in a true sense, but if you take a cursory look, it might fox you. So that's why I just put this case here. All right, so that brings us to the end of the quiz.